well as the disciplines as well.
It's also really great that so much support is being offered for children, families, children, parents across these different disciplines. So that's how we embed access to early help, is through every pocket of service.
Okay, Daisy. Okay, shall we? Thanks, Daisy. Okay, so welcome everybody. It's 5 past now, so we're going to get started and we'll finish promptly at 3 o'clock. So welcome. I'm Judith Weiss, Chief Operating Officer at the For Baby's Sake Trust, and delivering this webinar this afternoon with Asha. Asha, do you want to introduce yourself?
Yeah, I'm Dr. Asha Patel, clinical psychologist and founder of Innovating Minds.
Thanks, Asha. So today our webinar, bi-monthly webinars, this one is on parental mental health through a trauma-informed lens, healing child-parent relationships. And I'm going to move through a series of slides and then I'll hand over to Asha, and we do have that opportunity for you to ask questions at the end. So please do add those. Daisy will be monitoring the chat. Thanks, Daisy. Just about emotional safety, the themes we'll be discussing for this hour could be difficult or triggering, so please do check in with yourself throughout. It's okay to pause, breathe, step away. Our cameras are off, but it is really important that you protect your own emotional safety, and your well-being comes first. We have to protect ourselves in order to protect those babies and families that we work with. So the aims of our webinar this afternoon and what we'll be focusing on is understanding how trauma can underpin mental health, why services struggle to engage with parents, the links between parental mental health and child outcomes, how professionals can hold both accountability and compassion when working with parents, and practical ways to embed trauma-informed principles into everyday practice. So hopefully we'll be able to cover those as we move through, but yeah, do put your questions in the chat. That's just the agenda as we'll move through, and hopefully moving to about 20 to 3 when we'll do that Q&A section. As Daisy has said, your cameras and mics are turned off for all attendees, but just use the chat to interact with us. This is being recorded and it will be distributed afterwards, which will give you access, and please do feel free to share with colleagues. So first of all, I'm going to start this section, and I'm from, as we said, the For Baby's Sake Trust, sharing some of our learning. Just want to start with around parents' mental health. In a YouGov survey that we commissioned, in the first 1,001 days of parenthood, which is from conception to baby's second birthday, 50% of parents told us they experienced a rise in mental health challenges such as stress, anxiety, depression, suicidal thoughts, or self-harm. And 34% of parents overall reported more conflict in their relationship during these important 1,001 days. And 1 in 10 of dads said they turned to alcohol or substance more during the first 1,001 days of their child's life. And that's closely linked to their emotional mental well-being. And also in the YouGov survey, there was gaps in professional support. So 28% of the dads in the survey reported that a professional asked them about their mental health or emotional well-being during their baby's first 1,001 days, compared to 62% of mums, so much lower proportion. And 40% of mums reported feeling supported by a professional during this time, compared with just 19% of dads. And 1 in 10 of parents overall said there was no support available to them. 1 in 5 parents didn't know what support was available, and 1 in 4 mums feared being judged or blamed. So really shocking statistics that there's more to do for us to support parents in this important time. Just going to share a video which is part of our trauma insight tools, which really helps to show the wheel of adversity, that if we don't provide the support for our parents, how the cycle continues through generations of the impact of trauma in childhood that then goes on into parenthood. It's just a short 2-minute clip which we're available for you to use following the webinar. Great to see so many thumbs up as we played that video there, and hopefully it lays the foundations for as we lead through the session and Dr. Asha's Patel's session following mine. At the For Baby's Sake Trust, we like to have resources, make resources that you can share. So on the back of this is also a PDF diagram as well, and on the back it's really gives some pointers about how to ask questions that often it's difficult to open up those questions with parents. So please go and take a look on our website and download, and it's really helpful using that motivational interviewing to really support our parents, so that we can then support them, especially in the early years and in their parenting journey. The trauma adversity wheel is part of trauma insight tools. There's 2 more, which are 2 booklets, one to support working with parents that have already that have had trauma histories, but then another one to work with children that may have experienced trauma. So please do go over and have a look at those. So in the ONS, in partnership with Loughborough University, this is where they showed the real link and correlation between parents' mental health and child outcomes. And you can see for a child having a parent who experiences mental ill health significantly increases their probability of also experiencing ill health. On the same, also, when a child has mental ill health it also increases the probability of parents in experiences mental health. So we can't divorce the two. So that's just a diagram really that brings out some of the findings from that report. And how parental's mental health and child outcomes are closely linked. The probability of a child presenting at hospital with mental health issues nearly doubles when their mother experiences mental ill health too. And girls are both more likely to experience mental ill health and are affected more by parental mental ill health. And the probability of a mother experiencing mental ill health nearly triples if the child presents at hospital with mental health issues, whilst the probability of a father experiencing mental ill health nearly quadruples. So really the importance of thinking about both parents and mental health. Having previously found that a child's mental ill health impacts their school attendance, additional analysis has shown that their mental health negatively affects their attainment in maths, both directly and by increasing their level of absence from school, which we know is obviously the case that it impacts the learning for children as well. So please do go and have a look at that source that was published this year, but it also really sets the context of this webinar. So at the For Baby's Sake Trust, we're a trauma-informed organisation and really use the trauma-informed principles of safety, trust, choice, empowerment, collaboration, and cultural consideration. So these are really important for an organisation and our staff, which really underpin our work, how we then are able to work with parents and families and babies and children. And we haven't got time to go into those principles today, but I know Dr. Asha Patel is going to build on some of those. There's also the 4Rs, which comes from another source around thinking about what is trauma-informed care from the SMHSA, which is a substance abuse and mental health services, which is about realising how trauma can impact and then being able to recognise it, then be equipped to respond, and then also how we can resist that re-traumatization, which many practitioners may worry about when working with trauma. And again, we're going to build on that. So just another way to be able to reflect on our practice. Do these underpin your work in your organisation? So a reflective question there for you in the chat. So how do we engage with engaging parents with our services instead of accepting them to engage with us? Routine inquiry is really important. There's a need for more consistent professional inquiry and curiosity about parents' mental health, along with increasing professional knowledge regarding their responsibilities and links to trauma. Recording, it's really important that improvement is required in the recording and sharing of information, so parents don't have to repeat their story. What works? We need to better understand the evidence and learning around which intervention works in which settings. And barriers. There are several reasons why parents' needs are not acknowledged or responded to appropriately. For example, the stigma around mental ill health, especially for fathers, and the fear of social care intervention. We need to really work to address these barriers, and this remains vital. Accountability and compassion. Parents need to be seen and heard and their feelings validated. Services need to reach out and not expect parents to reach in. This quote always resonates with me. Trauma compromises our ability to engage with others by replacing patterns of connection with patterns of protection. And so please do go over to look at our resource page on our website. And this is just a flavour of some of the resources that we've got, which really underpin working in trauma-informed way when we're supporting parents with their mental health as well as domestic abuse. So there's a QR code that you can scan. Please do go and have a look. What's really helpful there is lots of mindful and relaxation and videos for you and for you to use with parents as well. We've also got some upcoming training workshops, part of What we do at the Trust is also support upskilling practitioners, especially with domestic abuse, in the important 1001 days starting in pregnancy. So again, 2 QR codes that we'll share after the webinar as well, or Daisy will pop into the chat as well, that you can sign up for. So now, delighted to be able to hand over to Dr. Asha Patel for the second section. Thanks, Asha.
Thank you so much. Welcome, everybody. I'm Dr. Asha Patel, and my background is in forensic mental health services. So I worked in medium secure services and actually recognised that a lot of all of my patients experienced childhood trauma and weren't able to access the help and support. So what we do now is upskill frontline practitioners like yourselves to be able to offer trauma-informed support for children and families so they can access early intervention and support. It's really important that throughout this session that we recognise that not all children and families will need access to specialist services. These are children and families that are experiencing trauma, and therefore the ways that they're presenting, the difficulties that they're experiencing are very much around trauma reactions. So we're shifting that narrative from focusing on behaviour to really being curious around what has happened to that individual, that young person, that parent, that they're responding in a way that their body, their nervous system is responding in a way that actually is affecting functioning. It might be affecting relationships. It might be affecting their child-parent relationship as well, but also their experiences of how they engage with you as a service. Now, in this session, I'm going to be touching upon some difficult conversations as well. I might touch upon a little bit around suicide, self-harm, personality disorders as well. So if there's anything that I'm saying in this session that feels a little bit uncomfortable, then please do listen to your bodies and step back. Now, the reason why we're talking very much around listening to your body is because actually what we know about trauma is that it's stored in our nervous system, it's stored within our body. Often we think that trauma is stored cognitively and that we need to get parents and children to talk about and relive their experiences of trauma. But what we do know that actually remembering is not recovering. So re-talking and resharing and getting people to open up actually is not helping their recovery, their healing journey. What that actually can do is actually re-traumatize the individuals that have experienced the harm. Now, everything that I'm going to be talking about today and the models that we implement at Innovating Minds through the Healing Together programme is based on this model. Just having a couple of technical difficulties. So we have to start with curiosity. Actually looking at how do we consolidate our learning and shift from being trauma aware to actually embedding trauma informed practice, becoming and being trauma informed, but also trauma responsive. So many of you will have had and received trauma informed training, but actually the implementation process and the interactions that it'll have on the shop floor will look very differently. So we need to be more curious and more open to thinking, actually, how do we shift from being trauma aware to trauma informed and then trauma responsive? What we're also looking is around that action. It's really unfair to upskill frontline practitioners to be more trauma aware, but actually not provide the resources and the support to embed that into daily practice. Often what we find is that practitioners don't feel comfortable, they don't feel safe, they don't want to get it wrong, they don't want to use the wrong language, they don't want to say something that might cause additional harm. So the result of that, we don't do anything, or we continue to work the way that we're used to. Through safety also comes with developing your practice as well. So how do you professionalize your practice so you're looking at evidence-based outcomes, that you're monitoring, you're accessing quality clinical supervision, you're accessing ongoing CPD, and then how do we leverage those relationships? How do we center relationships at the heart to make things more sustainable? How do we leverage the roles within your organization and service so those people of influence, those decision makers, are actually understanding what it's like around on the for implementation to take place, and also the challenges that you're experiencing. Now, we've heard the word trauma a lot today, And it is actually a very popular term that's been used, trauma-informed practice. It's like become the new buzzword. But I want us to hold on to what do we actually mean by trauma? Because what we can start to do is start to put things into a hierarchy, that we say that different forms of abuse, or it might be domestic abuse or other forms of trauma, can start to become maybe more significant than others. What today is all about is actually remembering that trauma can be many things. It could be something that's happened to somebody or something that hasn't happened. So for a young person, for a child, a baby, it might be that actually they've not able to have that connection with their primary caregiver, because the primary caregiver is experiencing mental health difficulties, and that might be related to the trauma that that parent and carer has experienced. But it's always about their experience that defines their trauma. So when you're reading notes, when you're engaging with a parent, with a family, with a child, it's really about thinking, okay, what is it from their perspective? How have they experienced it? How has their body experienced it? That's actually led to them experiencing the difficulties that they are. Now, I spoke about trauma being stored as sensory memories. Often we can think about trauma being stored in the brain, in the mind. But if you think about it, our body is so much bigger than our brain. So our bodies are constantly scanning for information, cues of safety and cues of threat. Our babies are constantly scanning. Trauma survivors, our parents and our carers that have experienced maybe domestic abuse and other traumas, they'll be more hypervigilant. They might be even more in meerkat mode. So they're constantly scanning for perceived threat. And remember, it's perceived threat. So actually the experiences of trauma that they've experienced and what the child has experienced is stored within their nervous system. It's protect them for future occurrences. So when you're thinking about how do you engage and show up and what does that look like, how can you help? What we're really thinking about is how can they tap into your nervous system? Now, this is what we call co-regulation. How can they attune into your nervous system to help their nervous system to feel safe, calm, and regulated? What does that look like for you? Now, to be able to think about that, you have to be very much aware and attuned to your own nervous system. So this only works because you have to have an awareness. How are you feeling in that moment? How are you feeling around that baby, around that parent and carer? Because actually, if you're feeling dysregulated or you're feeling dysregulated because actually your own trauma reactions are showing up, don't forget we are humans as well, then actually that will impact on you being able to work directly with that young person or that parent carer, and actually they'll sense it. So a lot of the time it's focused in on us. How are we showing up? How attuned are we to our own body? Too often we're too focused on doing to others and forgetting about ourselves. So we've all experienced our own traumas before. I haven't come across anybody that hasn't experienced some form of trauma. Now, what that might mean for us as a practitioner might be actually that you've suppressed feelings, or you're not attuned to how your body is feeling, or you might have grown up around family scripts to say, actually, we don't pay attention to those emotions. We just get on with it. We suck it up. There's people out there that have got it a lot worse. And therefore, we can start to neglect our own body. But remembering our traumas are stored as sensory memories, and therefore, when you're working with parents and carers and children, we're supporting them through body-based strategies to help them to process the trauma, because we know trauma isn't processed cognitively. Now, how does that show up in frontline work? Well, it might be that somebody's been triggered by something. So it might be the smell of burnt toast. It could be the front door banging. It could be quietness within the household. And not always people are aware of their own triggers. So they could be unconscious. They don't have that awareness. It could be significant times of the year. It might be milestones. It might be football matches, etc. So it's unrealistic to think that you're going to know everybody's triggers, or that they are aware of what's being triggered in their body because of the sensory experience that they're feeling. But for you, it's holding that curiosity of thinking, what is it that's taken place? What is it that's showing up? Now, often you might see that your parents and carers have been diagnosed with mental health disorders. So you might hear terms around personality disorders and anxiety disorder, depression, you might see that there's strategies that have been used, such as self-harm, or there's suicide ideation, or it could be some form of addiction through substance misuse. Now, if you think about the classification of mental health disorders and where it came from, it's a classification of symptoms, and it originated to help people to be able to classify, to diagnose, to access and find support, and typically from America because of the way the private healthcare system works. But if you look at these symptoms that are on the screen, you'll actually see they're very closely linked to things around post-traumatic stress disorder. But if you think about them from a trauma-informed lens, what we can actually see is these symptoms that are showing up, that are presenting, could be in response to the trauma that individual's experienced. So if you think about somebody that has been diagnosed with emotional personality disorder or borderline PD, that you might have heard it as, it's their nervous system that has learned that they need to quickly react quite quickly, and they react quite intensely to perceived threat. A result of that, they feel these emotional tsunamis, that the feelings of emotion is not quite regulated as we might feel anxious or angry. So this can look like that they're being sensitive to rejection. It could look like they're being manipulative. It could look like that actually they're feeling quite suicidal, or their mood's fluctuating, that they go from being quite high to quite low. But also what you might get on the flip side of that is the hypoarousal state. So the low state, the state of nervous system that's in shutdown. And that looks like around feeling numb, being quite slowed down, feeling quite helpless. So you're thinking about the people that you're working with, it's really also thinking about, okay, what state is their nervous system in? Is it hypoaroused? Is it hyperarousal? And therefore, how is it responding to the threat, the perceived threat? Now, the other thing that you might see is actually when they're with you, it doesn't present in this same way. So sometimes you can get this conflict occurring between what's on the notes, what's written versus what's in front of you. Who's this parent carer in front of you? And it's really important to remember that actually don't forget you're being that co-regulator. So you're helping that parent and carer to feel safe and calm and regulated in that moment with you. So for them to have those moments is helping them. Now, thinking about how do we support the parent and child relationship, it's very much around how do you upskill and equip the parent and carer to know actually how is their body and brain working, what's happening when they're feeling safe and unsafe, how can they bring their nervous system back into state of feeling regulated. Because don't forget that actually their experiences, their trauma, that they actually don't, we often think they're older, it happened years ago, why they're not acting their age. But when trauma gets triggered, you don't act your age, you act the age the wounds were created. Now that's really powerful because we can make the assumptions. And then we also like think about, okay, so what does that look like in practice? How can we think about, okay, so this is a parent that might be struggling to interact with their child. It might be that they just don't have the capacity. They feel so drained, they feel so tired. It's so exhausting to feel all those symptoms that we've talked about, that actually having capacity for their child. It doesn't mean they don't care, they're not loved. It's just that their body is depleted. The nervous system is in that state of survival because it's had to learn to be that way because the experiences that they've experienced. Now, it might be quite helpful to think about mental health on this continuum around that we all have a mental health. And therefore, at this top of the continuum, a person with no mental illness or disorder has a positive mental health. But something may happen. It might be that there's an anniversary coming up. It might be that there's a bereavement. It might be something that's going on with their child, that actually they start to experience some difficulties with their mental health. So they might start to experience some symptoms. Now, as opposed to focusing on symptoms, what I always say is look at functioning. What is the impact it's having on their daily life and where is it problematic? The same goes for things around like suicide ideation. Often we have parents and children that are experiencing suicide ideation. They're having thoughts around suicide a lot of the time. And then we get a little bit freaked out. I think, oh my gosh, what's the risk? What does that look like? But just remember to put it into context that for some people, that actually it might be keeping them alive, the thought that they know that they have something. So it's their strategy. Now, I don't want us to call these strategies unhelpful because in that moment they're meeting an unmet need. And therefore, they're not unhelpful coping strategies, not maladaptive. They have unintentional consequences that become unhelpful. But in that moment, these strategies are being used because there's an unmet need. And often it's around that they're feeling unsafe, they're feeling unregulated, their nervous system is in that state of survival, that they constantly then are on this hyperarousal state, they're hypervigilant, and they're seeking that support. Now, they're doing it the best way that they can. And that's always what I want to leave you with today. It's that it's not just about how we're perceiving it as practitioners, but really looking at it through the lens of what is it that they've experienced, what is going on between that relationship, and what can we do to support that co-regulation to give them some relief from that distress that they're experiencing internally, but also that their body's constantly scanning for cues of safety. So how do you become and offer that cue of safety? So I'm just going to stop there, and I believe we're going to questions. Oh, you're on mute.
Thanks so much, Asha. Brilliant presentation there, and I'm sure we've got lots of questions in the chat, have we, Daisy?
Yeah, we do. Thank you to everyone who's engaged in the chat. If you do want to put forward any more questions for our speakers, then do use the Q&A function so we can make sure that they don't get lost. But I'm happy to jump into questions now if you two are ready. Great.
Yes, great.
So Helen has asked, how can we support staff / volunteer wellbeing to help them best support families, given that staff and volunteers may well have lived experience of trauma themselves?
I'll take that, Asha.
Yeah. So this is a great question. And I think this is around how do you start with training? So, and training that actually looks internally as opposed to general training. So you've got the trauma awareness around understanding trauma and its impact on the body and the brain. But then really offering that space internally to think, okay, how does that apply to me? So having that ability to think about how attuned is it that I am to my nervous system, to the way that I'm feeling, and then thinking about the wider system within the organization. So this is a thing where it's no good just saying we're delivering trauma-informed practice to the people that we work with, but internally you're not treated from a trauma-informed lens either. So having line managers that are really aware of what does trauma-informed practice look like, how do you access quality clinical supervision for you to be able to process the impact of vicarious trauma? How are you having the space and the time to reflect? When I had that session with that family member, actually I felt quite triggered, or do you know what, that child really pressed my buttons that irritate me, that bore me. Have you got the ability and the capacity to have those conversations in a safe environment? Because that's actually how you'll start to learn and how it changes practice as well over time. It's just not a one-off training session, it's a culture that's created internally.
And I think, Asha, we can't underestimate how much someone being heard, listened to, and their feelings validated really helps that person or that parent that we may be working with as well. So that's as important as thinking, we're not asking anyone to treat the trauma, but actually if someone feels heard and their feelings validated, and then be able to come back to that session or that person after you've had maybe supervision or discussions within the team. And I just want to also add, for those on the call, if you go to our website, there's emotional safety plans that you can use specifically for pregnancy, birth and beyond, but also there's a designer for professionals as well. So really to think about, especially maybe after a difficult session with a parent or a difficult scenario that has made maybe triggered you, you can then actually think and reflect with your manager or in supervision about what is it you need, what you need to be able to feel safe again and to be able to process what's happened. So yeah, that's just a resource for you to look at.
And I think as well, really reflecting on who are you. Too often we struggle to sit with uncomfortable feelings. And therefore, when you're with a parent, you always want to fill the gap, that uncomfortable silence, as opposed to sitting with it. So are you somebody that's a problem solver, that you're saying to somebody, have you tried this? Let's try this. Let's refer here. Or can you be somebody that can just sit in that emotion and let people experience it? For too long, we keep getting people to talk about feelings instead of actually letting people feel their feelings. And by feeling it, that's how we process them.
Thank you both so much. Asha, we have someone asking in the chat about where they can find access to Healing Together. If you wouldn't mind popping a link in the chat, that would be super helpful. And thank you, Annie, for reaching out about that. I'll hop back to the Q&A now. I've had quite a few questions come in, so I'll try and get through them as quickly as we can. Robin asked a few minutes ago, there is pressure to supplement trained practitioners with apps and AI. Is it possible for these digital services to deliver trauma-informed services? What should designers and practitioners be aware of?
Yeah. Shall I take that, Judith?
Yes, yeah.
Yeah, so really interestingly, I've had lots of conversations recently around development of technology, and particularly because I'm an Innovate UK assessor, so I look at the new innovations that are coming in from technology. Now, how do you design something that's trauma informed and responsive? Very much is about that user engagement, the look, the feel, the images, the colours, the language that's used. So too often what's happening is it's over engineered by these techies, these developers that can do a lot, but then they're forgetting about the user experience. So I think it can definitely supplement and support people. It can never replace that human connection. So we can't get away from that. What it can do is provide access to support and hold somebody in a space whilst they may be waiting, or they can access some self-help resources. But it's really to make sure that in the technology that they use, that the modalities that it's built on align with trauma-informed practice. So if you've got a modality around CBT, cognitive behaviour therapy, it doesn't truly align very well with trauma-informed practice and the neuroscience and relational-based approaches. And that's when you can see then there's a misalignment, and it really shows through. Also, if you're working in a setting that's heavily based on punitive, consequence-based approaches, rewards-based, so if your technology is rewarding people and this kind of carrot and stick approach, then it's not really trauma-informed or trauma-responsive. And therefore, that's when you start to see that actually it's misaligned. It's got all the buzzwords in it, but in practice, it doesn't work.
And I think, yeah, just building on what can happen with some of the apps, though, it can start to break down some barriers, would you say, as well? I don't know if you see that, so that, it removes some of the shame and stigma about seeking the support in the first place. But like you said, just being able to hold, but then needing to lead on to that support. What do you think about that?
Yeah, so I think it also depends on people's help-seeking experiences, previous help-seeking experiences. So a lot of families that you'll be working with hasn't had great help-seeking experiences. They've probably also been traumatized by the system that was built that should have supported them. So therefore, having less contact with professionals might be preferred. And again, it's not going to be a one-size-fit-all approach. But if they then have a negative help-seeking experience with some technology as well. And what we know is so many people are also starting to chat GPT, use Claude, put in symptoms, and then it's coming up with things that are actually not right, that there's errors in what it's coming up with. So we really have to think about how do we show up and be available to be able to support more children and families. So how much of your work is taken up by admin work that actually we could get AI and technology to do, so then more families and children have connection with people, which technology can't replace.
Wouldn't that be great to remove some of the admin processes for many of us on the call?
Absolutely. And it's possible, yeah.
Thank you both. I'm going to flout my chronological questioning because I've had one with a few thumbs up and an upvote. So this is just a reminder for anyone lurking in the Q&A function that if you like the look of a question, if you click the arrow to upvote it, or if you put a heart or a thumbs up, I'm going to notice it a bit more quickly and I'll be able to put it forward to our speakers. So Claire has asked, and this is a popular question, there is a growing number of people recognizing their own childhood was traumatic and had ACEs. However, others who know no different and do not see the adversity they have faced and almost minimize it. Any tips for supporting parents to recognize their own childhood was not healthy in a trauma-informed way?
You start, Asha.
Yeah, so I think it's really importantly about treading carefully. It might be that actually unconsciously they're not aware of it, and therefore you really have to think about what is the need to try and get them to relive or make those connections. But what you could focus on is actually where is it getting at? Where is it showing up? How is it that they're feeling in their body? What is it that's taking place? How it's affecting relational health? So is it that actually there's mistrust going on, and therefore we think about mistrust? So instead of trying to do that thing that we used to do, is go back to it and find where's the source, where has it come from? Because that makes sense cognitively. We think, okay, this happened to you as a child and therefore X, Y, Z. So it's no wonder you're feeling this way or you're experiencing these difficulties. But actually that doesn't change the person's reaction to it and their response and how they're feeling about it in their body. So in a trauma-informed way, you'd be okay with not knowing, or that parent carer not being able to identify that they've experienced childhood trauma that is still showing up now. What you would be doing is supporting that parent and carer to feel safe, understanding that actually when their body is feeling unsafe, when they're feeling dysregulated, it's sending messages up to their brain and it's flicking them into safety survival mode. And a response to being in safety survival mode, that actually that they might struggle to then be able to attune and engage with their child. It might be they find it really difficult to do some more cognitive based tasks around perspective taking and planning and sequencing. So it feels very overwhelming for them. So that's what you would do. You wouldn't be so focused on what is it that's happening. Too often it's us that are curious and we want to find out the nitty gritties. But actually, we don't need people to relive and acknowledge their trauma to still be able to work with them.
And at the Baby Safe Trust, when we deliver the programme, it's the power of video about getting some messages across. Just when you were talking there, Asha, I was thinking about the circle of security and the shark music video as well. I don't know if many, we can pop that in the resource as well, but it helps parents to think, oh yeah, that's what's happening for me. So it's just talking about where they might be triggered by their child crying or some behavior that then is then taking them back to their own experiences. So yeah, power video as well about getting some of those message about what might be happening is also useful.
Thank you both. I will try and dig out that shark music video in a second and pop it in the chat. Right, another popular. Oh,
What happened?
that was me trying to dig away behind the scenes on YouTube to find the shark music video and accidentally playing the old one. Okay, Lindsay has asked, hi, are there specific strategies for use with children who may have been exposed to trauma?
Yeah, so I'm going to take some strategies out of the Healing Together programme. So the Healing Together programme is very much around supporting children to learn about their body and brain. How is it feeling and what's happening when they're feeling unsafe, when they're feeling dysregulated. Now, the strategies that we kind of are using with them is body-based strategies, discrete body-based strategies. Now, you've heard a lot around mindfulness taking place, but for some young people, for some adults as well, mindfulness actually can, it might trigger something around dissociation taking place. And you're asking somebody to sit with their current thoughts, which may be distressing for a long period for them to experience. But also you might know as a practitioner if that individual has experiencing dissociation in that mindfulness activity. So using body-based discrete strategies mean that they'll always have them with them. So things like the breath, of taking in those deep breaths and sending it down as far as they can, because they'll always have their breath with them. That also helps with the vagus nerve as well. You've also got things around progressive muscle relaxation, so clenching, whether that's the fists, whether that's the thighs, whether it's the toes, rocking backwards and forwards, or swaying. We see children do this and we ask them to stop, particularly in schools. We see it as disruptive, but really thinking about it, a lens of actually that they're regulating, they're soothing their nervous system so they can be in a place to feel safe. When you look at things around mindfulness, colouring, etc., and we might call them distraction techniques, just think about how invalidating that is, that we're saying, do you know what, we're going to distract you from your feelings, from your emotions, from that intensity that you're feeling, and here's an activity to do to distract yourself from that. What those tools are actually doing is helping them regulate, they're more soothing, more calming, regulating tools. So just changing the language can help with that, and introducing those tools. What I'd always say as well is let them know that it's like a buffet. Here's some strategies, here's some different techniques, but do what feels right for you. So when you're setting it up, always do it as an opt-in based approach, and always ask them to pay attention to how their body is feeling. If it's feeling uncomfortable at any point, it's okay to opt out. Thank you, Daisy.
Yeah, no worries at all. Thank you everyone for upvoting and thumbs up in questions. Please do continue so it can help me to filter. The next most popular question is from Isabel, who asks, if trauma is stored in our nervous system and remembering isn't recovering, then how effective would you say traditional counselling services are for those with trauma?
It's definitely yours, Asha.
So yeah, when you look at the research, I'm presenting at the Trauma Conference in Oxford. It's the largest trauma conference worldwide. You look at all the Gabor Mate, Dr. Bessel van der Kolk, they talk around actually talking about it is not enough for recovery and for healing. So remembering it and reliving it. So it's what I call it, it's nice to have because it's nice to be heard. But then how do we get to a position that trauma is being processed? And that doesn't happen cognitively. So we're still using where we feel like you have to have counselling, you have to have talking therapy to be able to access that specialist support. But the research is demonstrating more and more often that actually things like CBT are not actually supporting people that have experienced trauma. Because if you think about traditional talking-based approaches, it can be whether it's person-led or whether it's CBT-based or other modalities, but they still require you to have be switched on from a cognitive basis. So if you think about Dr. Dan Siegel's hand-brain model, for you to be able to access talking therapy, you're usually in a place of feeling safe, calm, and regulated. So your thinking part of the brain is online. But the moment that actually this young person or this parent and carer is feeling dysregulated, their thinking part of the brain is switched offline anyway. So therefore, they can't access all the strategies and the resources that they have when they're in talking therapy. So when I was working on the wards, a lot of my patients, always either I'm regulating them, helping them to feel calm and regulated. But when it was Friday afternoon or the weekend and they're feeling dysregulated, I'm not there to be able to offer that support and go through the talking therapy. So what I say is actually why it's important to upskill you as frontline practitioners, because actually you could be more efficient. You can support people from an earlier perspective to minimize the impact of them needing counselling in the future. And ideally what we've seen is you can have the bigger impact than I could do as a clinician. And that's why I don't offer therapy. It's because how long it can take and whether it works or not is quite questionable as well. But people typically engage with it because we keep telling people that this is what you need, and we stick families and stick children on waiting lists. And then when waiting lists don't occur, we stick them on another waiting list and say you've got ADHD, you've got autism, there's some neurodiversity showing up. But we've neglected to think about the trauma and how trauma reactions are showing up.
Thanks, Esha. Judith, did you want to add anything, or shall I move on to the next question?
No, you can move on. Yep, that's brilliant. Thanks,
Amazing.
Esha.
Smita has asked, can caring for a baby re-trigger implicit memories from when they were parented? And if so, how can the parent-infant relationship be supported to account for this within universal services, e.g., health visitor who is supporting a mother distressed by her baby's cries?
Yeah, I can just come in and then actually you can probably build from there, but just from a more practical, this as a health visitor, my background's in health visiting as well, but many health visitors are now trained using and supporting some of the tools around the newborn behavioural observation and also the power of using the video interaction guidance for those that are trained in it to be able to support the parent in that space. They're so valuable for the parent, often thinks that their baby doesn't love them, but so by seeing and using things like video interaction guidance can really help practitioners like health visitors to be able to support their parent, to be able to see that that's not their baby, that's them when they're a baby. But I'll let Asha come in with some of the. Do you have another lens on that as well? Not another lens, but
yeah, absolutely.
science.
So I think as well as thinking about when that mum is feeling distress, that they're recognizing that they're feeling that way, so they can take a moment to come out of that state of distress. So there's that recognition, that's awareness. So actually, the health visitor can support that parent to think about what does that distress feel like when it's happening, or the build up to it. And the easiest way to start with this is about paying attention to the body, because we're so used to paying attention to our body because of physical health needs, then actually really getting people to map out that when this happens, or when I'm anticipating that baby's going to be crying because it's hungry, or the certain times, or might be certain cries that can be triggering in terms of the noise. What does that feel like internally? So they can bring that some awareness to it to be able to know, actually, I need to take a breath, or I need to go here, I need to do this, and this works for me. So recognizing it as actually, and laying it on the table in the sense that, okay, this is happening, but how can we support you to feel regulated, so then that baby is met with a parent and carer that's feeling more safe, calm, and regulated. Because if a parent's interacting with that child whilst they're feeling distressed, it's only going to distress the baby more. And that screams and those cries is going to keep continuing. So you get this vicious cycle taking place.
Yeah, and really important for dads as well, so that that dads are supported in that early perinatal space as well, to be able to say how they're feeling without that shame or stigma, so they can get the support that they need, so that the baby then gets the support it needs from its parents.
Thank you both. I'm going to try and squeeze in a couple more questions then we can wrap up. This has been upvoted a couple times and it's quite practical, it's a specific case. So Justine has asked, if this is happening to a baby in family contact, for example, baby has learned over its short 7 months to stop crying, stop babbling, and to avoid eye contact with birth parent, what/how do we protect the child? Birth parent has had all the support possible but doesn't engage and doesn't speak to child, shows no affection. What other strategies could be put in place?
Do you want to come in first, Sasha?
Yeah, I can do. So I guess this would be looking at your safeguarding strategy for this baby, because the baby's doing what it can to communicate. So we have different survival responses. So you will have known around the fight, freeze response, and we've got the befriend response as well. But actually, if you're observing that during contact, that baby's gone into shut down, it might be disassociation as well that's taking place, then that's definitely thinking around safeguarding for that baby. And is it in the baby's best interest that they're still having contact with birth parents, and for you to do an assessment on that. But I think if you look at it from a lens of safeguarding, that might help to identify what other intervention support is needed for this baby, particularly when you've put as much support in as possible for parents. Now, I've seen the word engage flying around a few times. I'm just going to take this moment to take the opportunity to say, what does engage look like? We have this perceived kind of definition, or what does it look like? How does it show up? But the fact that maybe somebody's still attending, somebody's still picking up your calls, that might be engagement as well. So really question what you mean by engagement too. Judith, is there anything you want to add?
Yeah, no, just in terms of, the safeguarding, presumably if it's in contact, then the baby's in foster care as well. But it is really being able to feed back what's being recognised, how the baby is communicating. So, so that is fed back. So it is in the best interest for that baby. Yeah, really hearing what that baby's saying, always trying to tell professionals. Yeah.
Thank you both. What do you think? Appetite for one more question, or shall we wrap up? Conscious that lots of people are leaving. Thank you for the updates in the chat.
So, should we move the slide? Yeah, thank you so much, everyone. Got to move the slide. Thank you so much. Thank you so much, everyone. It's 14:59. Great timing and some fantastic questions. Hopefully that really built on the fantastic presentation. Thank you, Dr. Asha Patel. And I'm sure there's going to be lots more questions as well, and reflections following this. So please do reach out to both us at the For Baby's Sake Trust and at Innovating Minds if you want to find out more about the Healing Together programme. But again, thanks so much. Please do share the webinar recording with your colleagues and when you get it, and enjoy the rest of your afternoon. Look after yourselves too. Asha, anything to close?
Yeah, no, if you are interested in more content, then do follow me on LinkedIn. That's where I typically hang around. So yeah, we've got, I thought we saw a hand up, but no.
Yeah, I think it's when people are doing emojis. Thanks for all the thumbs up, and please do take it into your practice. I'm sure you've taken away some tools and strategies. It's been great being with you this afternoon.
Great, thank you everyone. What I'll do is I'll export the questions from the Q&A and we can have a look between the three of us and see what we can send over as written answers. As mentioned, you'll be getting the recording sent to you, and do scan the QR code to sign up to the next webinar from the For Baby's Sake Trust. We'll be collaborating with Advocacy After Fatal Domestic Abuse to have a discussion around domestic abuse interventions and approaches to domestic abuse. Thank you so much. Thank you, Judith. Thank you, Asha. It's been a brilliant session.